This is newborn care in 15 minutes. So, what happens in the hospital after a baby is born? The first thing we want to do is see if the baby's doing okay. And we typically assess an APGAR score, which is an acronym to look at how well the baby is reacting to its new environment. Typically, nurses will calculate it, but we can also calculate it ourselves. We look at the appearance, pulse, grimace or crying, activity, which reflects tone, and respiratory effort. And a perfect score would be 10, which is uncommon for patients to get. And a bad score would be closer to 0 to 5. Ideally, these numbers will go up over time, and these scores can predict some short-term outcomes, but give us a way to objectively measure and consider interventions in the moment. Now, the other things that we do in the hospital form what I call the newborn trifecta. The hepatitis B vaccine, which can help prevent chronic hepatitis B, as that is very common if someone is infected as an infant with hepatitis B. Erythromycin ointment, which can help prevent chlamydial and gonococcal conjunctivitis. And vitamin K, which helps prevent intraventricular hemorrhage, as babies do not have vitamin K at high enough levels in their system to help produce clotting factors. Now, one of the other things that is starting to be added to this trifecta of Hep B vaccine, erythromycin, and vitamin K is RSV vaccines. So, this is a vaccine that can be given prenatally during the 32 to 36 week gestational window if the baby is going to be born in the fall or winter. But it can also be given to infants during their first fall or winter. This may occur during the baby's initial birth and hospitalization, or it may occur later. And what's been shown to do is reduce RSV-related hospitalizations by about 80%. Because RSV is the most common cause of hospitalization for infants in the United States, this has been very important for us to consider as we start to modernize our treatment modalities. Now, babies usually lose weight after they're born, but the amount they lose is going to depend on the type of nutrition they get, such as formula or breast milk, what type of delivery method they had, such as vaginal delivery or a cesarean, and other metabolic factors. So if babies are losing weight, we need to know if the amount they've lost is too much. And for that, we use the newborn weight tool, or NEWT. What we can do is plot their weight over time compared to their birth weight to see if it's reassuring. As you can see, if a baby is losing too much weight, they would fall below the orange or red lines, which would be indicative that we need to change our methods. If they're losing this much weight, we can increase the feeding frequency, supplement with formula, or even increase the calories of the formula. We also monitor babies for neonatal hyperbilirubinemia. Babies do not break down unconjugated bilirubin as effectively as we do as adults, so we use bilirubin nomograms to assess if there is need to treat. After checking an infant's bilirubin level, which can be done first transcutaneously or using a blood stick, we decide if their levels are dangerous based on three big factors: what their gestational age was when they were born, how many hours it's been since they were born, and if they have the presence of neurotoxic risk factors for getting worse, such as sepsis, ABO or rhesus factor mediated hemolysis, or vital instability. This example shows that the infant is above the threshold for phototherapy, which is indicated by the blue line. We would want to put this baby under phototherapy or under lights to help convert the indirect bilirubin into a soluble form to reduce the risk of kernicterus, which is the deposition of bilirubin in the brain. This can also reduce the risk of seizures, cerebral palsy, hearing loss, and other cognitive issues. If the bilirubin goes even higher, above the yellow and red lines, we might end up needing to do exchange transfusions, where we use apheresis to help remove excess bilirubin from the bloodstream. Problems can pop up anywhere for bilirubin metabolism, but most of the time, it's unconjugated hyperbilirubinemia due to physiologically low enzyme levels, inadequate nutrition, or conversion in breast milk. However, for shelf exams and for step exams, there are some rare causes that you should consider. If an infant has a high unconjugated bilirubin level, you can consider hemolytic disorders like G6PD or an autoimmune mediated hemolysis, Gilbert syndrome, which is benign except in periods of stress, and Crigler-Najjar syndrome, which would be a very severe syndrome that would present very early in life. If an infant is presenting with a conjugated hyperbilirubinemia, they may have Dubin-Johnson syndrome, which has to do with impaired excretion of the conjugated bilirubin. This is classically noted by a black liver. Or you may have something like Rotor syndrome, which is impaired excretion as well, but is typically benign. Finally, there also may be surgical abnormalities that may present with conjugated hyperbilirubinemia, such as biliary atresia, where the bile duct and gallbladder may not be formed properly. During this first hospitalization, we also do a couple other screenings. This includes mandatory genetic screening for all infants in the United States to look at common genetic disorders, hearing screening to evaluate for deafness. CMV is the most common form of deafness, and so if we have an abnormal result, we may check CMV levels in the infant. Finally, we also do congenital heart disease screening. This is done by checking a pulse ox preductally, so in the arms, and postductally, often in the legs or in the left arm, in order to see if there's a difference in the amount of oxygen as you traverse the cardiovascular system. Before a baby leaves the hospital, they should also have voided within 24 hours of birth, have stooled within 48 hours of birth, which is also called passing meconium, and they should also receive routine guidance in order to ensure their safety at home. This includes talking about sudden infant death syndrome, or SIDS, and how to prevent it. The most common things we think about counseling parents on is that babies should sleep alone, on their back, in a crib, which are the ABCs. You should also avoid secondhand smoke. Infants should also ride in a rear-facing car seat. They should be fed 2 to 3 ounces every 2 to 3 hours, including waking up overnight. Once they're older, they can start to space this out, but for the first couple months, this tends to be the case. In order to know if they're hydrated enough, they should make the same number of wet diapers with urine as they are days old. So, for instance, a newborn that is 4 days old should make 4 wet diapers. And after about a week, they should be somewhere in the range of 5 to 7 wet diapers per day. Infants should also take vitamin D drops, even if they're breastfeeding or using fortified formula, as breast milk does not have vitamin D, and fortified formula is not being consumed at a high enough amount after a baby is initially born. So, how do I know if a baby is growing okay when they come to see me in the clinic? Well, at every visit, each baby is going to be measured for their weight, their length, and their head circumference. And then this is compared to standardized values based on the WHO and CDC. So we can plot over time what those numbers look like to see if they're going along a similar trajectory. We want to make sure that their measurements over time stay close to the same percentile, ideally within 2 lines up or down of where they were previously. Now, let's go through a couple scenarios. Let's imagine that you're measuring the head circumference of a baby and it's too high or growing too quickly. This would be concerned for macrocephaly or hydrocephalus or other causes. Often we get an ultrasound or an MRI to see if there are concerns for neurological issues. If head circumference is decreasing, we would be concerned for microcephaly, which would be indicative of potential congenital vertically transmitted infections, some other genetic syndromes, and you should definitely get imaging with ultrasound or MRI. With regards to weight, either weight for age or weight for length, if a baby is too high on these metrics, we want to consider nutritional patterns. They may be feeding the baby too often or using a high-calorie supplement. One example is something called Nido, which is a supplement that is marketed by Nestle to add to formula that is unnecessary and can cause very high weights for infants. Now, we also want to watch out for babies that are too low for their weight for age or weight for length. In these situations, similar to before when we talked about the newt, we would want to increase feeding frequency, consider supplements, and consider changing the density of the formula that we're using. If this is profound, we may need to refer them for a metabolic workup and consider issues related to failure to thrive. Now, if someone is getting too tall in the first couple months of their life, we often just monitor them. They may have syndromes, and later on, we might need to get bone radiography to assess their end plates and see if they're growing beyond expected, but this typically requires specialist consideration. If a baby is not growing in terms of their lengths, we also need to be concerned similar to their weight. make sure they're getting enough feeding, and adjust the frequency or supplements or density, and then refer them to a metabolic expert if it's pronounced. So, examining a newborn can feel scary because they're very floppy, but they're actually quite resilient. And I'm going to present a couple different things that we think about for a newborn exam so you can notice the big abnormalities that we would look out for. So, here on the left, I'm going to present a full newborn exam, and we're going to go through each piece. First, I start at the head. I always look at the baby's skin, and you may often notice neonatal acne on their cheeks. This is benign and does not need to be treated and will go away. You can often recommend to parents, that they can use a little bit of lotion and make sure that they're not using too hot of water when they clean their babies. Now, continuing to examine their head, we should also check their fontanelles. Fontanelles are soft areas that are still present after birth from the fusion of the sutures in a baby's skull. The posterior fontanelle, which is a triangle on the back of the head, is typically fused before a baby is born. However, the anterior fontanelle, which you can see being palpated in the picture, is typically open and present until 12 to 18 months. This can often indicate hydration status. So if a baby is really dehydrated, it might be sunken, or if they're having hydrocephalus, it might be bulging. And so you just want to make sure it's approximately flat. Continuing down from head to toe, we do a red light reflex to look at infants' eyes. Ideally, the red light reflex should be symmetric in both sides. However, if it's not symmetric, it could indicate something wrong with the retina. If you see a white reflex or leukocoria, that could be concerning for retinoblastoma and should indicate a referral to ophthalmology. Continuing downward, I'll then check the baby's mouth. I often palpate inside their mouth to see if they have an intact palate, because having a cleft lip or cleft palate could present issues with regards to their sinus and also with regards to their feeding and growth. I also will look at their clavicles, start to look at the rest of their back, and then I will listen to their heart and lungs. Now, if all of that sounds good, I can continue onward and look at their back. On their back, I look for every baby to see if they have a dimple. As you can see on the right, a dimple is a hole at the top of the butt that can indicate that there is an underlying neural tube defect, such as spina bifida. When patients have this, we should refer them for imaging to see if they are going to develop some sort of spinal dysarthria. If they don't have this, that's great, but we may also notice something called congenital dermal melanocytosis, or CDM. In the past, this was called Mongolian spots, but this is totally benign discoloration that can happen on an infant's back, and it's important to note this because it can look like bruising. And we want to note it as early as possible because if it's present later on and someone is exposed to possible violence at home, this would help us distinguish between bruising and a congenital presentation. We also want to check an infant's hips by doing the Barlow and Ortolani exams. This involves adducting the knees and pressing downward to see if you can dislocate the hips, which would be the Barlow maneuver. And then the Ortolani maneuver would be trying to push the hips anteriorly or forward while you abduct the knees. If you feel a clunk, that is suggestive of developmental dysplasia of the hip and would warrant either an ultrasound if an infant is young or an X-ray later on. You could also assess this by looking at skin folds. And so as you can see in the picture on the bottom right, there is an asymmetry in the skin folds with a crease near the inguinal crease on the left leg that suggests that the hips may not be growing in the same way and would warrant an ultrasound. I always do a genital exam for all male infants, trying to see if their testes are descended bilaterally. I always check for femoral pulses. And then I also will assess for primitive reflexes. These are reflexes that are present only during the first year of life and typically go away over time, but are often something fun that parents are interested in experiencing because they're going to go away. So one reflex is the grasp reflex, where if you put anything inside an infant's feet or in their fingers, they will automatically squeeze. Similarly, they might have a rooting reflex, where if you rub their cheek near their mouth, they will automatically turn and try to feed on it. Finally, there's the moro or startle reflex, where if you lift an infant up and go to drop it, it'll automatically launch its arms outward. All of these things are normal things that typically go away by 1 year and indicate proper neurological development. So, when does a baby get vaccines? We have a separate video that goes into depth of vaccines, but I'm just going to repeat some of the information here. The CDC vaccine schedule tells you all you need to know about when to give vaccines for infants. In the first year of life, most injections are done at 2 months, 4 months, and 6 months, and we can combine these into fewer shots in order to make them easier to give. At around 6 months, we also consider giving the first flu shot, which may need a second dose in order to be maximally effective. Once babies have gotten 2 initial doses of those flu vaccines, they can continue to get it every season, just like they'll get for the COVID vaccine. At 1 year of age, they can start to receive live attenuated vaccines, including the MMR and varicella vaccines. These are vaccines that are done again at age 4 and hopefully cover them for life. However, we often check titers of antibodies in pregnant patients in order to assess if they are immunized. This can help us risk stratify to decide if they're at risk of vertically transmitting some of these infections, including varicella and rubella. So what are the takeaways? Every infant should get hepatitis B, erythromycin gel, and vitamin K when they're born. And some of them will also get the RSV vaccine depending on if their parent had received it before they were born. You should always monitor newborns' bilirubin to see if they need phototherapy or exchange transfusions. Weight loss is normal in the first 2 weeks, and then babies should continue to grow along stable trends that we can compare to CDC and WHO standards. The newborn exam can help us catch problems very early, including retinoblastoma, developmental dysplasia of the hips, and neurological concerns. Finally, the CDC vaccine schedule can outline all the vaccines that we need. And for a newborn, this is typically at birth with hepatitis B, and then more vaccines at 2 months, 4 months, 6 months, and at 12 months.